amlodipine, losartan, or lisinopril. 6. Silent side effects your doctor dismissed as just aging. Margaret Chen, a vibrant 71-year-old retired school librarian from Columbus, Ohio, embodies a challenge faced by countless seniors managing chronic conditions. For 6 years, she faithfully took her lisinopril every morning, a routine prescribed to keep her blood pressure in check. On paper, her numbers were exemplary, consistently pleasing her doctor during routine checkups. Yet, despite these seemingly perfect readings, Margaret's daily life was far from optimal. By noon, a persistent dizziness would set in, followed by an overwhelming exhaustion that rendered her nearly incapacitated by 2 in the afternoon. She found herself unable to concentrate, often nodding off halfway through a chapter of the novel she was reading, a hobby that once brought her immense joy. Attributing these debilitating symptoms to the inevitable march of time, she confided in her daughter, "I think I'm just getting old." Her daughter, however, refused to accept this explanation, instinctively sensing that something more might be amiss. She insisted on a second opinion, a decision that would ultimately prove transformative for Margaret. The new doctor meticulously reviewed Margaret's comprehensive medical chart. To their surprise, he did not alter her diagnosis of hypertension. Instead, his astute observation led him to make a crucial adjustment. He changed her medication. What he uncovered during this reassessment was profoundly shocking to both Margaret and her daughter. The subsequent improvement in Margaret's health, a dramatic reclamation of her quality of life, holds vital lessons for every individual grappling with blood pressure management, particularly those in their later years. As Dr. Michael Carter emphasizes, if you or a loved one relies on amlodipine, losartan, or lisinopril, this understanding could fundamentally reshape your perspective on blood pressure treatment and foster a more proactive approach to your well-being. Drawing from years of extensive experience working with older adults, Dr. Carter acknowledges the undeniable life-saving capacity of these 3 medications. Their efficacy in controlling hypertension and preventing cardiovascular events is unequivocally established and not in question. However, a significant concern arises in the manner in which they are frequently prescribed, dosed, and monitored, particularly in adults over the age of 65. This protocol, he argues, is often dangerously incomplete, overlooking crucial nuances inherent to the aging body. Consequently, many seniors experience adverse side effects that are routinely dismissed as mere consequences of aging, when in reality, they are clear manifestations of the medication itself. This critical oversight can lead to a significant decline in quality of life, attributing preventable discomfort and risk to an unchangeable biological process. The purpose of this comprehensive discussion is to illuminate 6 critical aspects of these medications that most patients are never adequately informed about. It is imperative to engage with all 6 points, as each holds distinct and significant implications for your health. For instance, one particular side effect, often mistakenly blamed on natural aging, is in fact directly attributable to the prescribed pill, impacting millions. Furthermore, a specific blood pressure reading that appears perfectly controlled on paper could paradoxically place individuals at a heightened risk of hospitalization. Understanding these nuances is not merely academic. It is foundational to advocating for optimal care. If you or someone in your family takes any blood pressure medication, assimilating this information could genuinely empower you to engage in a more informed and impactful conversation at your very next doctor's appointment, potentially altering the trajectory of your health. Before delving into the specific points, it is essential to establish a foundational framework, a distinct lens through which to interpret all subsequent information. This framework is aptly termed the dose assumption trap, and its insidious mechanics operate on several interconnected pillars. The first pillar of the dose assumption trap posits that your doctor's initial prescription is invariably based on established clinical guidelines. While this adherence to protocol is entirely appropriate and professionally sound, what many patients fail to recognize is a crucial detail regarding the very foundation of these guidelines. The vast majority of clinical studies that inform these recommendations were primarily conducted on cohorts of individuals in their 50s and 60s. Critically, these guidelines often do not fully account for the physiological complexities of a 78-year-old patient who might be managing 3 other chronic conditions and taking multiple additional medications. The aging body processes pharmaceutical agents profoundly differently than it did 2 decades prior, a factor frequently underrepresented in broad guideline application. This discrepancy means that a standard dose or approach, while suitable for a younger demographic, may be far from optimal or even safe for an older individual whose metabolism, kidney function, and overall systemic resilience have naturally evolved. The second pillar illuminates how the very dose designed to meticulously control your blood pressure readings on paper may, in a far more subtle and insidious manner, be quietly generating a range of symptoms that you, and potentially even your healthcare provider, are mistakenly attributing to the natural process of aging. These seemingly benign, yet persistently disruptive symptoms can manifest as pervasive fatigue that drains your vitality, episodes of dizziness that compromise your balance, a persistent brain fog that diminishes your cognitive clarity, or the discomfort of swollen ankles that restricts your mobility. It is crucial to understand that these are not, as commonly assumed, inevitable and unalterable components of growing older. Rather, they frequently represent medication side effects, potent indicators of a physiological imbalance hiding in plain sight. Their insidious nature lies in their commonality with age-related changes, making their true pharmaceutical origin easy to overlook or dismiss. The third and final pillar of the dose assumption trap underscores that a controlled blood pressure reading meticulously recorded on your chart does not automatically equate to optimal blood pressure for the nuanced and unique needs of your specific body. A numerical value that appears perfectly textbook in your medical file, perfectly aligned with clinical targets, might concurrently be detrimentally impacting your daily existence, diminishing your quality of life. This phenomenon highlights the core of the dose assumption trap. The numbers appear satisfactory, leading to a pervasive assumption by everyone involved, patients, families, and even clinicians, that the medication regimen is functioning perfectly. Consequently, the crucial question of how you genuinely feel day to day, the subjective experience of your health, is often left unasked, unheard, and unaddressed. It is paramount to internalize this comprehensive framework as we proceed through each critical item on the following list, recognizing that a focus solely on numerical targets can obscure a patient's true well-being. 3 drugs, 3 completely different mechanisms, and why it matters, which one you're on. Consider the experience of Robert Morales, a 68-year-old retired truck driver from San Antonio, Texas. During a routine physical examination, his blood pressure was found to be elevated. His doctor promptly issued a prescription for amlodipine with the simple instruction, "Take this once a day." Robert, a naturally inquisitive man, asked a fundamental question: "What does it do?" The doctor's concise reply, "It lowers your blood pressure," effectively concluded the conversation. For 2 years thereafter, Robert diligently followed this regimen, swallowing his pill daily without truly understanding the intricate workings of the medication within his body, or the specific rationale behind choosing amlodipine over other available options. This significant gap in his understanding nearly had severe consequences for his health, a testament to the fact that medical adherence without comprehension can be a risky undertaking. What Robert, and potentially many others, were never fully informed of is a fundamental truth about these commonly prescribed medications. Amlodipine, losartan, and lisinopril, despite their shared objective of lowering blood pressure, achieve this goal through entirely distinct physiological pathways. Amlodipine, for instance, belongs to a class of drugs known as calcium channel blockers. Its primary mechanism involves relaxing the smooth muscles embedded within the walls of your blood vessels. By facilitating this relaxation, the blood vessels widen, a process called vasodilation, which in turn allows blood to flow through with significantly reduced pressure. This direct action on vascular tone is crucial to its therapeutic effect. In contrast, losartan operates through a different biochemical cascade as an angiotensin receptor blocker, or ARB. This medication functions by specifically blocking the action of a potent hormone called angiotensin II. Angiotensin II is a powerful vasoconstrictor, meaning it signals your blood vessels to tighten and narrow, thereby increasing blood pressure. By blocking the receptors for this hormone, losartan prevents these constrictive signals, leading to wider blood vessels and lower pressure. Finally, lisinopril is classified as an ACE inhibitor, angiotensin-converting enzyme inhibitor. Its mechanism involves preventing your body from producing the very enzyme responsible for creating angiotensin II, the same vessel-constricting hormone targeted by ARBs. By inhibiting its production, lisinopril indirectly reduces the constrictive forces on blood vessels. The critical importance of distinguishing between these different classes lies in their unique pharmacological profiles. Each class inherently carries a distinct array of potential side effects, interacts with other medications in different ways, and presents varying degrees of risk that can become significantly more pronounced and clinically relevant as an individual ages. Understanding which specific medication you are taking, and more importantly, why it was chosen for you, is not a matter of trivial curiosity. It is an absolutely essential component of informed self-care and patient advocacy. Therefore, a proactive and fundamental action step is advised. At your next medical appointment, ask your doctor this precise question: why did you choose this specific medication for me and not one of the other classes? If the response you receive is generic, vague, or lacks specific tailoring to your individual health profile, it signals a deeper conversation that is unequivocally worth pursuing, as the side effect profile of each drug class can dramatically impact your lived experience. The side effect your doctor calls normal, that is anything but normal. The nuanced realm of medication side effects is where the distinction between what is considered common and what is truly normal becomes critically important, especially concerning one of these three widely used drugs. Consider the case of Linda Hargrove, a 73-year-old former postal worker residing in Richmond, Virginia. For 4 years, Linda had been diligently taking amlodipine to manage her blood pressure. For the majority of those 4 years, she experienced increasingly significant swelling in her ankles. This wasn't merely a minor puffiness. The edema became so pronounced that it compelled her to discontinue wearing many of the shoes she had comfortably worn throughout her entire adult life, replacing them with wider, more accommodating footwear. Linda conscientiously raised this concern with her doctor on at least 2 separate occasions. Both times, the response she received was remarkably consistent. That's a common side effect. It's harmless. Don't worry about it. Trusting her physician's assurances, Linda adapted to her new reality. She purchased wider shoes, diligently elevated her feet every evening in an effort to alleviate the discomfort, and resigned herself to what she believed was an unavoidable consequence of her medication. This acceptance continued until one afternoon when the swelling escalated dramatically, reaching an alarming severity. Her daughter, witnessing Linda's distress, promptly took her to urgent care. There, a more thorough examination revealed that the noticeable peripheral edema was tragically masking a far more serious underlying circulatory problem, one that had been silently and insidiously developing, unmonitored and unchecked, for over a year. This narrative underscores a profound danger in dismissing common side effects as harmless. Linda's experience is, unfortunately, far from rare. Extensive research published in esteemed journals such as the Journal of the American Heart Association has meticulously documented that amlodipine-related peripheral edema affects a substantial proportion of patients, impacting up to 10% of those prescribed the medication. Furthermore, the incidence and severity of this swelling are known to increase significantly with advancing age and higher dosages. Despite its prevalence, this particular side effect is routinely trivialized in many clinical settings, often being brushed aside as a cosmetic or minor inconvenience. However, the underlying physiological mechanism reveals why this perception is dangerously incomplete and potentially misleading. Calcium channel blockers like amlodipine exert their primary effect by dilating or widening the arteries. Crucially, they do not dilate the veins at the same proportionate rate. This inherent imbalance in vasodilation leads to a pressure differential that causes fluid to leak from the capillaries into the surrounding interstitial tissue, manifesting as visible swelling, particularly in the ankles and feet due to gravity. While younger patients often possess robust compensatory mechanisms that can manage this fluid shift, older adults present a different physiological landscape. Many seniors already experience reduced venous return, a natural consequence of aging and potentially other circulatory conditions. In this demographic, the uneven dilation caused by amlodipine can initiate a detrimental cascade. Swelling directly contributes to reduced mobility, as walking and movement become more difficult and uncomfortable. This reduction in mobility, in turn, exacerbates the decline in overall circulation. Further circulatory impairment then significantly elevates the risk of falls, a devastating outcome for many elderly individuals. Therefore, to label this cascade as harmless is to fundamentally misunderstand its potential for serious, long-term health consequences. If you or a loved one is experiencing swollen ankles while on a blood pressure medication, it is absolutely paramount not to simply accept it as an unavoidable given. Instead, you must proactively request a comprehensive medication review from your healthcare provider. Crucially, viable alternatives exist. A potential solution could involve switching to an ARB class medication, which operates via a different mechanism and does not typically cause this type of edema. Adjusting the existing dose of amlodipine, often to a lower strength, can also significantly mitigate the swelling. Furthermore, a strategy involving the combination of lower doses of two different classes of blood pressure medications can frequently resolve the problem while maintaining effective blood pressure control. Never concede to the response "it's normal" as a definitive final answer when a side effect is demonstrably altering your daily life, compromising your comfort, or increasing your health risks. Your quality of life is a non-negotiable aspect of your treatment. The cough that won't quit and what it's really telling you. While amlodipine carries its own distinctive set of considerations, another of the common blood pressure medications, lisinopril, can trigger a different yet equally persistent and often debilitating side effect that often goes unrecognized or misattributed. For those currently prescribed lisinopril, what follows may resonate with a painful familiarity, illuminating a struggle that has perhaps been silently endured. Consider the story of James Whitfield, a 69-year-old retired electrician from Knoxville, Tennessee. Approximately 3 months after commencing his lisinopril regimen, James developed a peculiar, dry, and relentlessly persistent cough. This was not the familiar cough associated with a common cold, nor did it bear the hallmarks of seasonal allergies. Instead, it presented as an irritating tickle in the back of his throat that would escalate into an uncontrollable coughing fit, simply refusing to abate. His concern led him to seek medical advice from a pulmonologist, where he underwent a chest X-ray, ruling out any immediate lung pathology. There were even nights when the incessant coughing kept him awake, fueling anxieties about more serious conditions like lung cancer. Alarmingly, throughout an 8-month period, despite numerous consultations with various medical professionals, not a single doctor bothered to ask him one simple yet profoundly critical question: what medications are you currently taking? This oversight highlights a systemic gap in patient evaluation. This specific type of persistent cough is, contrary to what James experienced, far from an uncommon side effect. The phenomenon of ACE inhibitor-induced cough, directly attributable to Medications like lisinopril affects a significant proportion of patients, with studies indicating an incidence rate of up to 15%. Some broader population studies even suggest that this number could be considerably higher, indicating its widespread impact. Esteemed medical publications, including the New England Journal of Medicine, have extensively reviewed and elucidated the precise physiological mechanism underlying this perplexing symptom. Lisinopril, by inhibiting the angiotensin-converting enzyme AC, blocks the breakdown of a substance known as bradykinin. Consequently, bradykinin begins to accumulate within the lungs, specifically irritating the delicate lining of the airways. This irritation then triggers a persistent, non-productive, dry cough that is notoriously resistant to conventional cough suppressants and over-the-counter remedies. For older adults, this incessant cough is much more than a mere annoyance. Its impact extends significantly into their overall quality of life and health. It profoundly disrupts sleep patterns, leading to chronic fatigue and diminished cognitive function. The forceful bouts of coughing can induce episodes of dizziness and lightheadedness, dramatically increasing the risk of falls, a major cause of morbidity and mortality in the elderly. Beyond these measurable physical risks, the persistent cough erodes quality of life in subtle yet deeply impactful ways that are challenging to quantify but impossible for the individual to ignore, affecting social interactions, comfort, and general well-being. If you have developed a new, unexplained, and persistent cough after initiating an ACE inhibitor medication, such as lisinopril, it is absolutely crucial to immediately inform your doctor. This is not a symptom to be endured or dismissed. The good news is that this is a known, well-documented, and most importantly, completely solvable issue. A straightforward solution often involves switching to an angiotensin receptor blocker, ARB, like losartan. In the vast majority of patients, this medication change effectively eliminates the bradykinin accumulation and consequently resolves the troublesome cough. Therefore, you should never be told to simply live with this particular side effect, as effective and readily available alternatives exist to restore your comfort and health. The silent potassium problem that nobody is checking after learning about the specific challenges associated with amlodipine and lisinopril. Losartan might, at first glance, appear to be a comparatively safer option within this trio of common blood pressure medications. However, it harbors its own distinct and potentially severe hidden danger, a landmine that patients on losartan and similar drugs specifically need to understand and monitor. This concerns a silent potassium problem that, alarmingly, often goes unchecked in routine medical care. Rather than detailing a single patient's experience for this particular issue, the collective hospital data tells a far more compelling and alarming story than any individual case study could convey. Both angiotensin receptor blockers, ARBs, like losartan, and ACE inhibitors, like lisinopril, share a well-documented physiological effect that, regrettably, receives far too little attention and proactive monitoring in standard clinical practice. These medications have the capacity to significantly elevate your body's potassium levels. The medical term for this condition is hyperkalemia, and the statistics are stark. Data compiled and analyzed by the American Journal of Kidney Diseases reveals that hospitalizations directly related to hyperkalemia in older adults who are taking these specific classes of medication are not only alarmingly common, but also demonstrably increasing year over year. This trend underscores a critical and often overlooked risk factor in the management of hypertension in the elderly. The underlying mechanism behind this potassium elevation is rooted in the drug's interference with a key hormonal pathway. Both ARBs and ACE inhibitors work in part by reducing the levels of a hormone called aldosterone. Aldosterone plays a crucial role in maintaining electrolyte balance within the body, specifically by signaling your kidneys to excrete excess potassium. Consequently, a reduction in aldosterone means that less potassium is expelled from your body leading to its accumulation. This physiological effect is compounded by the natural realities of aging. As we advance in years, kidney function undergoes a gradual and natural decline, rendering the kidneys inherently less efficient at clearing potassium from the bloodstream. This pre-existing age-related decline in kidney function then interacts with dietary habits. Many seniors, often with good intentions, consume foods widely promoted as heart-healthy: bananas, spinach, potatoes, sweet potatoes, and various beans, all of which are notably rich in potassium. Furthermore, the landscape of over-the-counter supplements often includes potassium-containing formulations, and many health-conscious adults utilize salt substitutes that are high in potassium chloride, frequently without a second thought regarding their cumulative effect. The combined impact of medication-induced potassium retention, age-related kidney decline, and a potassium-rich diet, potentially augmented by supplements, can lead to a dangerous and silent accumulation of potassium within the body. The most terrifying aspect of hyperkalemia from a physician's perspective is its often asymptomatic presentation. The condition frequently progresses without any discernible symptoms, offering no warning signs until it reaches a critical threshold where it can trigger a cardiac arrhythmia. This is a potentially fatal disturbance of the heart's rhythm, which can occur abruptly and without any prior indication of trouble. The insidious nature of this silent problem makes proactive monitoring an absolute imperative. Therefore, if you are currently taking losartan, lisinopril, or any medication belonging to the ARB or ACE inhibitor class, it is not merely advisable, but absolutely essential that your potassium levels and kidney function are checked regularly and systematically. A minimum frequency of every 6 months is recommended to ensure vigilance. This crucial monitoring is not an optional add-on. It is an indispensable component of safe and effective therapy that, regrettably, too many patients are not consistently receiving. At your very next appointment, take the initiative to ask one direct and pertinent question: when was my potassium last checked? If your healthcare provider cannot furnish a clear, recent answer, or if this vital parameter has never been assessed despite prolonged use of these medications, it signifies a significant gap in your care that demands immediate attention. If you've been on one of these medications for more than a year and have never had your potassium levels tested, you are far from alone in this predicament. A widespread oversight that necessitates urgent rectification across patient populations. The blood pressure number that's actually too low, when your medication becomes the danger of all the potential pitfalls in blood pressure management for older adults. One particular scenario stands out as the most concerning for physicians, largely because it is so rarely and openly discussed. The blood pressure reading that, paradoxically, is actually too low, transforming the very medication intended to protect into a source of direct danger. This specific challenge illuminates the critical importance of individualized targets and careful monitoring. Consider the unsettling experience of Dorothy Flanagan, a 76-year-old retired teacher's aide from Scranton, Pennsylvania. Her blood pressure was consistently what her doctor enthusiastically termed perfectly controlled, often reading around 118/70. At every visit, her doctor would greet her with a smile, affirming, "Numbers look great, Dorothy." Dorothy, in turn, would smile back, reassured by the seemingly ideal figures. However, a profoundly concerning trend was quietly emerging in Dorothy's daily life. She was falling. These were not isolated incidents. She fell twice in her kitchen, once in her driveway, where she painfully scraped both palms on the concrete while instinctively trying to break her fall. Then, one Tuesday morning, her daughter discovered her lying on the bathroom floor. Dorothy recounted that she had simply stood up, and in an instant, the room went black, and she collapsed. The emergency room diagnosis was orthostatic hypotension, a condition where her blood pressure plummeted every single time she transitioned from a seated or lying position to a standing one. The medication that had been prescribed with the intention of safeguarding her heart was, in fact, directly jeopardizing her bones and her brain. The accumulating body of evidence regarding this phenomenon is both compelling and growing, challenging long-held assumptions about optimal blood pressure targets in the elderly. A follow-up analysis of the landmark SPRINT trial, a pivotal study on intensive blood pressure lowering, alongside a widely cited 2023 study published in JAMA Internal Medicine, has yielded critical insights. These analyses collectively found that aggressive blood pressure reduction in adults over the age of 75, specifically pushing systolic pressure consistently below 120 mmHg, was significantly associated with increased rates of falls, episodes of fainting, syncope, acute kidney injury, and dangerous electrolyte imbalances. These findings represent a significant reevaluation of what constitutes a healthy blood pressure for very elderly individuals. In response to this evolving understanding, major medical organizations, such as the American Academy of Family Physicians, have issued updated recommendations advocating for more relaxed blood pressure targets for adults over 75. These guidelines suggest that for many patients, particularly those with multiple pre-existing health conditions, maintaining a systolic pressure below 150 mmHg may be more appropriate and, crucially, safer than striving for lower, more aggressive targets. This shift acknowledges that the benefits of ultra-low blood pressure in this demographic may be outweighed by the increased risks of adverse events. To truly grasp the gravity of this situation, it is important to visualize the full cascade of events that can be triggered by overly aggressive blood pressure lowering. The process typically begins when medication lowers blood pressure too aggressively, beyond what the aging body can compensate for. When an individual then stands up from a chair or gets out of bed, blood naturally pools in the legs due to gravity. In a younger, healthier individual, the blood vessels rapidly constrict to push this blood back up to the brain, maintaining adequate cerebral perfusion. However, in older adults on aggressive blood pressure medication, the vessels may not be able to constrict fast enough or with sufficient force to compensate. Consequently, the brain receives an insufficient flow of blood. This critical lack of perfusion manifests as a sudden sensation of dizziness, a dimming or blacking out of vision, and a loss of balance. Instinctively, the individual reaches out for something to steady themselves, but due to impaired reflexes and vision, they miss their grasp and fall. The immediate consequence of such a fall is often a hip fracture, a devastating injury that frequently necessitates complex surgery. The subsequent hospital stay exposes the patient to the heightened risk of hospital-acquired infections, a common and serious complication. This is followed by a period of prolonged immobility during recovery, which in turn leads to significant muscle loss, further compounding weakness and frailty. The entire traumatic experience can also precipitate cognitive decline and depression, severely diminishing the individual's independence and overall quality of life. This entire tragic chain of events, from dizziness to cognitive decline, can be set in motion by a single, perfectly controlled blood pressure number on a chart, a reading that everyone in the room initially interpreted as unequivocally good news. Therefore, the critical action step for patients is multifaceted. First and foremost, ask your doctor to check your blood pressure, not just while you are seated, but also while you are standing. This simple but profound test, known as orthostatic vitals, reveals a crucial part of the picture that a seated reading alone cannot provide. Request these orthostatic vital signs at every single visit, making it a standard component of your checkup. Furthermore, initiate an honest and direct conversation with your healthcare provider about whether your current blood pressure target is genuinely appropriate for your specific age, your personal history of falls or dizziness, and your overall health status. It is crucial to understand that a systolic reading of 140 mmHg, for instance, might be genuinely genuinely safer and more beneficial for you than an aggressively targeted 118 mm shrews. The fundamental principle to embrace is that the best blood pressure for you is not always the absolute lowest number. Rather, it is the number that allows you to live safely, independently, and with optimal quality of life. The blood pressure medication checkup. 5 questions to bring to your next appointment. This comprehensive discussion on the nuanced realities of blood pressure medication culminates in a powerful and actionable tool designed to empower you in your healthcare journey. This tool is the blood pressure medication checkup, a set of 5 critical questions meticulously formulated to guide a productive and illuminating conversation with your doctor at your very next appointment. It is highly recommended that you take a screenshot of these questions, write them down, or print them out and bring them with you. These 5 questions hold the potential to profoundly change how your blood pressure is managed, shifting the focus from mere numbers to your holistic well-being. Question 1. Why am I on this specific medication and not another class? You are entitled to a clear, medically sound explanation for why amlodipine was chosen over losartan, or why lisinopril was prescribed instead of an ARB. The answer should transcend generic statements about what the guidelines say and instead be specific to your unique health profile, medical history, coexisting conditions, and personal risk factors. Your doctor should be able to articulate the specific advantages and disadvantages of your current medication for you, providing a rationale that demonstrates a tailored approach to your care. This question opens a dialogue about individualized medicine rather than a one-size-fits-all approach. Question 2. What is my blood pressure when I'm standing, not just when I'm sitting? As previously discussed, a blood pressure reading taken solely while you are seated provides only half of the essential picture. The other half, your orthostatic blood pressure, is crucial for assessing your risk of dizziness, falls, and fainting. An unrecognized drop in blood pressure upon standing can be a silent precursor to significant injury and a dramatic decline in independence. Insisting on this simple test at every visit is a powerful preventative measure that could genuinely save you from a dangerous fall, directly impacting your mobility and safety. Question 3. When were my potassium and kidney function last tested? If you are currently taking an ACE inhibitor like lisinopril or an ARB like losartan, and no one in your healthcare team is regularly and consistently monitoring these vital numbers, this represents a significant and potentially dangerous gap in your care. As highlighted, the risk of hyperkalemia and acute kidney injury is a well-documented concern with these medications, particularly in older adults. Proactive and routine testing of potassium levels and kidney function is not optional. It is an essential component of safe pharmacotherapy that needs to be implemented immediately if currently overlooked. Question 4. Is my current blood pressure target appropriate for my age and overall health? This question challenges the notion of a universal blood pressure target and instead advocates for an individualized approach. The ideal blood pressure target for a healthy 55-year-old is not automatically, nor necessarily, the appropriate or safest target for a 78-year-old managing multiple chronic health conditions. This question invites a deeper, more nuanced conversation about balancing the benefits of blood pressure reduction with the potential risks of overtreatment, especially concerning falls and other adverse events in the elderly. Initiating this dialogue demonstrates an informed and engaged approach to your health, which most conscientious physicians will appreciate and respect. Question 5. Are any of my other medications or supplements interacting with this one? Blood pressure medications do not exist in a vacuum within your body. They are part of a complex physiological system that can be influenced by other pharmaceutical agents, over-the-counter drugs, and even herbal supplements. For instance, common non-steroidal anti-inflammatory drugs, NSAIDs, can interfere with blood pressure control. Certain antidepressants can affect heart rate and blood pressure. Potassium supplements, as discussed, can dangerously elevate potassium levels when taken with ACE inhibitors or ARBs, Even seemingly innocuous over-the-counter cold medications can contain decongestants that elevate blood pressure, counteracting your prescribed treatment. Any physician who genuinely takes your health seriously will welcome this comprehensive inquiry, recognizing the importance of a holistic medication review. They will respect you more for asking these discerning questions, as it signals your active partnership in your own care. Conversely, if your doctor dismisses your concerns or discourages you from asking these crucial questions, it provides an invaluable insight into whether that particular relationship is genuinely serving your best health interests. Let us return to the poignant journey of Margaret Chen, the woman from our opening narrative who initially resigned herself to the belief that her debilitating symptoms were simply an unavoidable part of just getting old. Her new doctor, with a meticulous approach and a profound understanding of the nuances discussed here, did not merely reiterate her diagnosis. Instead, he made two crucial adjustments. He lowered her dose of lisinopril and strategically switched her medication class. The results were swift and dramatic. Within a mere 3 weeks, the persistent dizziness that had plagued her daily life vanished. The crushing fatigue that had stolen her afternoons lifted, replaced by a renewed sense of energy. Margaret joyfully declared to her daughter, "I feel like I got 2 years of my life back." Her blood pressure remained effectively well controlled, yet now the seemingly perfect number on her chart finally aligned with the vibrant, engaged life she was actually living. What I implore you to carry forward from this discussion is a fundamental principle. A blood pressure pill, at its core, should be a tool that helps you live better, not merely live longer at the expense of your well-being. If your current medication effectively controls a numerical reading on a chart but is simultaneously and quietly eroding your precious energy, compromising your balance, clouding your mental clarity, or diminishing your confidence, that is not a comprehensive treatment in its truest sense. Instead, it represents a significant trade-off, one you likely never explicitly agreed to, and one you possess every inherent right to question and challenge. The most beneficial blood pressure for you is not necessarily the lowest possible number that can be achieved. Rather, it is the optimal range that allows you to experience life fully, independently, and with the highest possible quality. If you are currently on any form of blood pressure medication, your experience holds invaluable insights. I genuinely want to hear your story. What specific medication are you taking? And perhaps most crucially, has anyone ever taken the time to sit down with you and engage in a thoughtful, comprehensive conversation about whether your current treatment regimen is still the absolute best and most appropriate fit for your evolving health needs and lived experience? Please share your story in the comments section below. Your candid experience could very well provide comfort, validation, and vital guidance to someone else who is watching this right now, navigating the exact same challenges and seeking answers. And if this detailed exploration has prompted you to think differently, more critically, and more proactively about your own blood pressure treatment, please consider sharing this video with someone you care about deeply. Subscribe to this channel to ensure you don't miss future essential health insights. I am Dr. Michael Carter, and I look forward to connecting with you in our next discussion.